For patients who come into cataract surgery with the specific goal of not needing to wear glasses or contact lenses after surgery, there is an ever increasing range of options. In general, the options fall into two broad categories. On one hand, you have what are called multifocal lenses. And on the other hand, you have what's called monovision, specifically done in the most modern case with light adjustable lenses. We'll take those in turn. In the first case, multifocal lens implants. I'll tell you what, I'll back up and explain that when we are kids, up to 30s, 40s, maybe 45 or 50 if we're lucky, the way that our eyes focus both in the distance and up close is with the natural lens inside the eye physically flexing and changing shape. There's a muscular contraction inside the eye that changes the shape of that lens, draws the focus in when we're looking at something up close, and effortlessly relaxes and lets the focus go out to the distance when we aren't. So that is the holy grail of this lens implant technology. When we figure out how to design a lens that can physically flex naturally the way that the normal lens does, we'll have really hit it big there in cataract surgery. We don't have that yet. What we have right now are compromises, and there are a couple compromises that may match different patients differently. There is no best option for any one patient or for any group of patients, say, but more specific approaches that work the best for each individual patient, given where they're coming from and what they want to get out of this. So in the first case of these multifocal lens implants, the way these lens implants achieve that goal is by splitting the light that comes into your eyes, either with a series of little concentric rings that are etched into the lens, or with a bimodal split where part of the lens focuses for one distance and another part of the lens focuses for a different distance. These lenses, by splitting the light, will help you achieve a range of glasses-free vision, generally done the same way in both eyes. So these lenses are usually paired with one another, where the same lens goes in each eye, or the same type strategy of lens. And there's a very high success rate with these lenses. Now, they make trade-offs, because everything makes trade-offs. There's no perfect lens. The specific trade-offs that you've got to be aware of in the case of multifocal lenses is, because of that light splitting, you are reducing the signal strength that comes into your eye by some bit for both the distant and the near vision to achieve both. You could think of a radio signal coming into the top of a house, into the antenna, and several radios on. You may be splitting that signal, so it may not be quite as strong. Now, it's a very efficiently split thing, but it's something that some patients can notice as a slight reduction in quality. Most people don't notice that, and the IOLs, the lens implants, are getting better and better and better at splitting that light effectively, efficiently, without causing a degradation in vision. So that generally isn't a big problem. What you can also see, though, is along with that splitting, you can get some scatter of light, such that a point of light in the dark can take on a ring-like or halo-like effect around it. That is something that a lot of patients don't notice, but a lot of the success of these lenses comes down to people's personality type as much as anything. Where your classically type B, easygoing patients don't notice that stuff, they have an easy time with these lenses, they have success much more quickly. Whereas your typical type A, very detail-oriented person notices every side effect or anything that is imperfect and takes some time to get used to that. So I always encourage people, with respect to multifocal lenses, to kind of profile themselves in those terms and think about what that means for them. All right. The second category of lenses that we use to gain a large or complete, in some cases, range of glasses-free vision is what's called monovision. Monovision makes use of monofocal IOLs, or lenses that focus well for distant or near vision, but not both. The leading edge of this technology is what's called the light adjustable lens, where we choose the initial powers of the lenses based on the scans that we get of your eyes, implant them both just like normal cataract surgery, But after the surgery, after you've healed, these lenses are adjustable in terms of their power. There's a period of time where we can use a targeted application of UV light in the clinic to adjust the power of the lenses and, in effect, edit the results of the surgery after the fact. So we get, number one, a high degree of accuracy of our choice of the lens, of hitting the target that we are aiming for, statistically better than any other lens. And two, patients get a sort of customizable monovision, where generally for the dominant eye, now not everyone does this, but generally for the dominant eye will be set for the best distance vision possible. The non-dominant eye will be set for some point closer in that gives the patient some functional vision. They may choose for it to be set perfectly at the computer, perfectly to read, but the idea there is that the patient is in control of that process and gets to change it if they need, up to a point. You get a few adjustments to make for these light adjustable lenses. And once you get it where you want it to be, we treat the whole lens in UV light and it doesn't move anymore. So you can appreciate the trade-offs of these lenses. The multifocal lenses have the advantage of the eyes being the same, of both eyes achieving more of a continuous range of vision. The disadvantage of some side effect risk and their lack of adjustability. The light adjustable lenses have the advantage of high accuracy due to the ability to refine the outcome after the surgery, and customizability with that monovision. The obvious disadvantages being the range of vision is achieved with the eyes not being the same. So there are trade-offs to each approach. A lot of this can depend on what patients are habituated to before they come to see us for cataract surgery, whether it be what they do in their glasses, what they do with contact lenses, also what they do in their daily lives. A lot of that helps us to guide these discussions and tailor our approach for the individual patient.